Good evening. Thank you. I would first like to thank CSI for having me here. And this is an important topic that I think is a little quite contemporary because there are a lot of new therapies that have come in the field of heart failure, which which merit our attention and which is in fact repurposing of some other drugs for other reasons. And it will be relevant to understand how we can shape better outcomes for these patients. So we all know that we have come a long way from how heart failure therapy started maybe 30 years ago from digoxin, although we are coming back to that right now. But it is significant to understand that over the years, if you look at how heart failure therapies have shaped patients' outcomes, the quadruple therapy that we use today, that is ARNI or RAS inhibition with beta blockers, MRA and SGLT2 inhibitors, when appropriately deployed, can significantly reduce mortality by the tune of 30 to 40% in a person with heart failure, which is a sizable thing considering that when we started off, digoxin, ARBs, ACE inhibitors individually did not make a difference of more than 5 to 10% in the reduction of the relative risk. And if you were to look at the lifetime benefits that these therapies have to offer, it is quite sizable. So for example, the panel on your left shows a 55-year-old male who comes with heart failure. If we were to give him the 4 drugs that we talked about, it can add a potential 15 years to his life. And similarly for a 65-year-old male, it can add almost 13 years. An increment by over 6 to 8 years over a 2 or 3 drug therapy treatment. So it's an incredible amount of benefit that we can give to our patients provided we invest in these therapies. And over the years, we have seen that in the past 25, 30 years, there have been many advances in heart failure therapeutics. But still, we should understand that despite all these therapies, there's a significant residual risk for cardiovascular events. HFpEF is a new baby in the town. It is a significant contributor to heart failure. And we have not all, which we should understand is in fact one of the major causes for heart failure. And we are not utilizing all heart failure pathways effectively. We have only limited therapies that can actually improve LV function and in terms of medical and therapies as well as interventional therapies. And obviously the cost of care over the cumulative period remains high. Therefore, we seem to need more than 4 or 5 pillars that we talk about. And if for any building to be in shape, you need numerous pillars, and our temples are a good way to look at them. So one of the important areas of heart failure is obviously obesity and heart failure, which contributes to HFpEF. And this was one of the major trials that came up a couple of years ago, which was seemingly dismissed, saying that when you used semaglutide, GLP-1 agonists, what you essentially did was you caused weight loss, and all the other benefits that you have in symptoms and change were all related to body weight, and essentially it seemed that it was weight reduction that led to benefits. But when these trials, when your pooled analysis of these trials was done and was published in Lancet in last year in April by Dr. Butler, it showed that the benefits were real. And if you looked at the time to the first heart failure event or cardiovascular death, there was a significant improvement in the semaglutide arm, seeming to say that there were some benefits of semaglutide which were beyond weight reduction, and that we'll come to in the subsequent set of slides. So what's new in 2025? ESC just had their session, the Heart Failure Symposium, and there are some learning lessons that we should take back home from the trials that had been presented at this session. So the most important them was digitoxin. Now digitoxin is not available in the country, but digitoxin has many benefits over digoxin, and digoxin had been relegated to sort of the dustbin for the past many years because it seemed from all the previous trials, including this trial that was published in 1997, that DIG was associated with increased mortality, and it did not in fact improve cardiovascular outcomes. It only reduced risk of heart failure hospitalization. But digitoxin overcomes some of the benefits, and that's why this trial was published, because it has a better absorption, it has better protein binding, it is eliminated by the liver, and therefore it's less likely to cause problems in patients with renal dysfunction. And they deliberately used a much lower dose, having learned from the DITCH trial. So what was the DITCH trial? Just basically encapsulating that they gave digoxin to patients who had heart failure, and patients who had AF, regardless of ejection fraction, they got digoxin. And what this trial showed was there was no decrease in mortality, although there were fewer hospitalization for worsening heart failure in the digoxin group. And when they looked at two subgroups of interest, one was women. Women were associated with worse outcomes when digoxin was prescribed. And when serum digoxin levels were lower, they seemed to be some benefit. So which is why when the DIGIT HF trial was designed, they made sure that they looked at these 2 points, that they used lower dose of digitoxin, they used patients who were NYHA class 2 with ejection fraction of 30% or less, or if they had ejection fraction of 40%, the entry criteria required class 3 or class 4 symptoms. They had 1240 patients that were randomized equally. And if you look at this trial, as opposed to all other trials of heart failure, nearly 70% of the patients had class 3 or class 4 symptoms. Remember, all the other trials had only majority of the patients were actually class 2. So what did they do? They followed up these patients every 6 months. The median duration of follow was 36 months. And what this trial showed was the composite outcomes of death or time to first hospitalization for heart failure was significantly lower in the digitoxin group. The absolute risk reduction was nearly by 5%, 4.5%, and the number needed to treat to prevent one composite endpoint was only 22, which is a powerful message to give, in spite of the fact that nearly 9 to 10% of the patients discontinued therapy, thereby showing that the powerful effect that digitoxin has in patients who have symptomatic heart failure. And this was across the board. Remember that these trials were on a whole lot of background therapy. Nearly 95% of them were on beta blockers. RAS inhibition was used in nearly 95% of these patients. MRA in 76%. SGLT2 was lower, 18%. CRTDs were used in 25%. So, these guys had good background therapy. And in spite of that background therapy, you could show a significant benefit in these patients, showing that digitoxin is something which is cheap, which can be used and should be deployed when available. And this is again the same subsets. Obviously, subset analysis should not be used, as this can be hypothesis generating, but yes, this is something of relevance for our patient population. Now, variciguat, coming to the second trial that I think we should be looking at is the variciguat and heart failure. Variciguat seems to have an equivalent role like SGLT2 inhibitors. And in the Victoria trial, they used a stepped up approach in which it was first started at 2.5 milligram, then 5 and 10. But it took a whole lot of patients a lot of time to get the therapy up to 10 mg, which was the target dose. So what this trial, the Velocity trial, was, they looked at the safety and tolerability of initiating therapy at 5 milligram in these patients. They had two groups of patients who had recent worsening of heart failure, or patients who had no recent worsening. And what they showed was the initial dose of 5 milligram versus 2.5 milligram caused a mild reduction in the systolic blood pressure by about 3 millimeters or so, and discontinuation happened in only a small number of people due to symptomatic mild to moderate hypertension, thereby saying that in more than 90% of the patient, you can start with the dose of 5 milligram and skip the 2.5 mg initial dose of which was used in the Victoria study. Now, coming back to the tirzepatide, which was a study that was recently published in NEJM in January this year, this answered the question whether these drugs are effective in reducing mortality. And again, this is just the summary slide. This was the SUMMIT trial. They included 700 patients, randomized them equally to tirzepatide or placebo, and the combined endpoint of cardiovascular death or worsening heart failure was significantly lower in patients on the treatment arm versus the placebo arm. And again, this was largely driven by worsening heart failure rather than cardiovascular death. But at least we have one study which shows that this drug seems to work in patients with worsening heart failure and HFpEF. So now you have a third pillar for patients with HFpEF. We have SGLT2 inhibitors. We had non-selective mRNAs like finerenone. Now this seems to be the third drug that we should be deploying in our in these patients. And what we need to understand, therefore, it's not weight loss alone. There seems other biological effects beyond weight loss by which these drugs are acting on these patients. Now, there are some, very unconventional ways in which people have been looking at heart failure, and now I'll come to the next set of few slides will be on this. Now, we should this is a microcurrent device that has been devised at the Charité University, and this is a special device that they have used in patients with heart failure, in which they put one lead into the right ventricle, and they've done a thoracotomy and put the other patch on the left ventricle. And what they've tried to do is give microcurrents, because in their background studies, they showed that there is a level of endogenous cellular interplay that requires microcurrents to be in place. These microcurrents are responsible for healing and communication between cells, and they devised this special device to see whether this microcurrent technology could actually remove sort of the interstitial edema. This is like an electrical osmosis, You have drugs and diuretics. This was an electrical osmosis that was removing fluid from the interstitium of the myocardium. They had done some background work and published previously that it worked. And this was a small trial in patients with non-ischemic dilated cardiomyopathy. None of these patients were eligible, got a CRTD or an ICD. They did not include these patients because they were afraid that it may cause some device interaction. So these were NIDCM patients who had significant symptoms, not improving. They got this device, and what they showed was a remarkable improvement in ejection fraction. There was a 5% improvement in LV ejection fraction, significant improvement in the 6-minute walk distance, significant improvement in symptoms, significant reduction in NYHA class, and because of this trial had to be prematurely terminated. So this is something that may work in the future, but obviously, you'll have to see how you'll implant this device in patients who have got an ICD or CRTD. This is in patients with NIDCM, but in patients who are significantly symptomatic, this has the potential to improve LV function and may be a powerful therapy in the future. So let me skip this slide. And what's even promising is what has happened the last 2-3 years. We have all read that, but I thought it would be important for you to recapsulate, to relook at this and at these evidences. One of the large trials, if this escaped your attention, I would like to draw your attention to this again, was this simple sort of therapy that came up, that was published in NEJM 2 years back. They gave this CRISPR gene to patients who had got transthyretin amyloidosis. And we all know that this is a largely fatal disorder, but look at this. This is a very important slide I want you to look at. One single injection given to a person and transthyretin levels fall by 96%. It wouldn't be amazing if one drug, one single dose could achieve that, and what this trial showed was just that. And recently, NEJM, again last year, came up with this important study. This is Dannon's disease. I wonder if you have seen that. I have seen some patients and treated some of them. It's an end-stage disease, horrible. People die in front of your eyes. This is due to a LAMP2 mutation. And what this intervention did was just one single gene drug, one single dose, and look at the expression of LAMP in the myocardial biopsies of these patients. LAMP mutation expression came back. These patients had improvement in LV function, significant improvement in heart failure. And therefore, gene therapy is here to stay. In the next few years, we're going to see that more often. And there are a whole lot of targets that are there for therapy. And some of this, these are some of the targets that we look at. So EAC this year looked at 2 such targets that were published. So one of the is SERCA. Remember, SERCA is a cytoplasmic endoplasmic reticulum calcium. Calcium is the way digoxin and digitoxin acts. So for many years, people have been seeing and reporting that SERCA levels are universally downregulated in all forms of cardiomyopathy. They hypothesized that if you could raise these levels, potentially patients could have improvements in LV function, improvements in contractility, reduction in ventricular arrhythmias. And in this trial, which was published in Music HF, they tried to show an improvement in some of these symptoms when they used this therapy. Another gene that is for target was the CS1 was the AB1002 gene that looks at protein phosphatase expression, and inhibition of protein phosphatase expression restores cardiac calcium energetics in the cell. And these was one of the another therapy in non-ischemic dilated cardiomyopathy in which they showed some preliminary improvement in NYHO class ejection fraction as well as heart failure scores. So this is something that may be coming. And the last two slides are on clonal hematopoiesis. Remember that all of us have expression of our cells which expand, and these clonal chip cells are supposedly causing inflammation in the heart. These are upregulated in patients with heart failure, and these have been used to benefit, and there have been some recent publications on that. And similarly, CAR T cells are responsible for myocardial fibrosis, and these can be used to reverse myocardial fibrosis. And recently, they have published in murine models that administering these cells, these CAR T cells, can potentially reverse myocardial fibrosis, improve LV function, and improve outcomes with heart failure. So gene therapy always comes with a whole lot of potential uptakes, but there are a whole lot of challenges as well. So to conclude, heart failure therapy is going to be a dominant cause of cardiovascular morbidity and mortality has been a major cause in the past few years and will remain so in the future. And high residual risk is there despite optimal current guideline-directed medical therapy. And many of these novel therapeutic targets will remain an important area of research and for us to deploy in our clinical practice. Thank you so much for your patience.
Thank you so much, sir, for sharing a very current, updated knowledge regarding heart failure. It seems really exciting, and probably 5 years from now, we may be seeing these therapies actually in action. I have two questions for you. One thing is that digitoxin DIGAs make a comeback in the form of digitoxin, which is not currently available. Where do you use digoxin in your practice?
So we are also currently doing a trial on digoxin in heart failure. We have, because of regulatory issues and one trial that is going to come is the decision trial. This is being done from Netherlands, and this will again deploy the same sort of digoxin in patients with chronic heart failure. So those trials the result of trial would be exciting to see. But in our current practice, it is being used in patients who have significant ventricular dysfunction, ejection fractions less than 30%, class 3 heart failure, atrial fibrillation. You are very cautious when you use it in patients who are women and thin-built. We are looking at digoxin levels at entry, but because of the issues with renal profile, whenever the GFR comes down, digoxin levels go up. So it is an area of concern, but yes, in our patients with heart failure who have significant symptomatic heart failure, digoxin still continues to be used.
Second question is, when you have both semaglutide and tirzepatide deserving patients with heart failure, which one you choose one over other when the finance is not a problem?
Well, we have started using semaglutide for heart failure. Tirzepatide is not easily available. It is being made available now, but not so easily available. But semaglutides definitely so. And when one of these oral GLP-1 agonists come in, I'm sure the utility will be even far more. But I do believe this is something that would be of benefit for many patients. But yes, many of these, the question will always remain that what is the contribution of weight loss. But I think so this is going to be increasingly shown that these drugs have a biological mechanism of action. And there is evidence to show that, in patients, when you look at the sub-analysis of many of these studies, they have shown that generally when you have weight loss, when you look at bariatric patients, when they lose weight, their NT-proBNP levels actually go up. But when you look at all these HFpEF patients, it has actually been shown that when their weight loss happens, their NT-proBNP also goes down. So there is some biological mechanism to affect, and these drugs should be of use in our practice.
Yeah, in continuation, sir, he asked, You said that I started using SEMA for heart failure, but it's basically HFpEF, it's not HFrEF.
That's right.
So all GLP-1s are for HFpEF.
That's not for HFrEF.
And also SEMA has a HFpEF, yeah.
That's right, not for HFrEF.
I was into the hall when DigitHF broke out in this hotline session, and I asked the question to the investigator. So in India, we use so much of digoxin rather than digitoxin. He said that it would have been better if you used digitoxin but not available. So can we extrapolate the same result in India, because it does reduce heart failure hospitalization, the same results in want of a trial on digoxin in India as of now?
Yes, so we do recognize the challenges with digoxin. The challenges are what we discuss about. Marked variability in levels of digoxin with not only renal, with worsening heart failure. When they go into worsening heart failure, they have rise in creatinine levels, eGFR changes, and therefore, you have concomitant therapy that may affect all these parameters. So, it is of real concern in these patients. But yes, when properly done, it is often possible to use digoxin wisely in clinical practice, and we have a RCT going on in our department. It is unfortunately only involving few centers, but we'll have to see what the outcomes are.
And when this topic pertaining to the novel therapies over and above the quadruple four, the fantastic four, the baseline four, what about omecamtiv post-galactic HF in the ones who, in the want of in stage D heart failure, in the want of destination therapy LVAD? Can this be brought to India, and we can defer and we can buy some time?
Yes, I mean, I think so. If you look at the absolute benefits, they are still not as good with these therapies. If you have looked at that graph where how much absolute risk reduction happens with some of these novel therapies, they are not great. So as of now, I don't think so that is something that we can easily deploy. But there are many other molecules available to us which would be easier and far more practical to use in our practice.
Lastly, sir, the CRISPR thing. There's a big hue and cry in the West about CRISPR, and you had a couple of penultimate slides. Do you think that is going to knock the horizon here, and it's on the anvil on Indian side?
Well, yes, I wouldn't say that it is really proven itself. There are so many, like we talked about, molecular targets which CRISPR can possibly address, and all of them have not been shown to be effective in heart failure as of today. There are many candidate genes, candidate molecules that are being investigated, but yes, they have the potential for specific forms of heart failure. Especially the chip is something that may be easy to do, because it has been shown that in NITCM, nearly 20% of patients have some form of chip happening. So targeting inflammation through some ways may be a new therapy in heart failure, and you might be knowing that colchicine is now being investigated in heart failure using this as a premise.
Thank you.
Nitish, amazing. Yeah, ma'am, go please.
Nitish, excellent talk.
Please go ahead, ma'am.
Actually, I was thinking of not a novel concept, but I have been reading that all these things are, of course, excellent, and they are going into further research and giving us lot of opportunities. Because I belong to a very old timer, When I did my MD in 1981, there was only digoxin. That's it. And you know how we have, with our professor, Bhandari was there, and he taught us that give a very small dose, Tripti, give a very small dose, itna sa. So we used to use sometimes 1/4 digoxin, and we kept the level below 0.05 nanograms per ml. And that has created, those days, not much of, inotropes and all those. That is one point. And second point, when we go through reading all these newer things, now there is a big hue and cry about the gut biotome, that where your gut has got the correct amount of biotome, this thing, then your heart improves actually. And there is a lot of research going on. Do you have any kind of effect of the gut biotome researched, or you are in the process of thinking about it?
Yes, so what you're saying is correct, and gut microbiome analysis is being done. And I didn't refer to one slide where one set of slides that we will at how heart failure is going to be looked in the future. So chip is also coming from some investigation to show some of it actually originates from the gut. And some of the other research is that is being looked at heart failure is the contribution of all these microbes and neurohormonal toxins to inflammation. So I'm sure the future is exciting, but as of today, I am not aware of any specific study that has looked at it in a targeted manner.
Thank you so much.
Nitish, wonderful talk, amazing discussion and everything. Couple of points. The digit trial that was there had a very careful monitoring of digitoxin levels. They used monitoring and then gave it. I think if you're going to follow it, you'll have to do the monitoring carefully.
Yeah, so in the digit heart failure trial, the levels were done at 6 weeks. After that, they didn't do any monitoring because they were not afraid of all these issues. They did do another level at 2 years, but that was for research purposes. That was not for monitoring. Anything else was done as per as clinically driven.
The SGLT2 inhibitor usage was just 14%. Dr. Savares probably should comment on that. Why was it just 14% SGLT2 inhibitor usage in a trial like DIGIT, which is much after the SGLT2 inhibitors came up?
Well, I really can't comment on that. But if you look at beta blocker therapy, RAS inhibition, MRAs, they were excellent. They were all above the ballpark figures.
Just one question. Excellent talk. Really interesting. You spoke about velocity trial. I would love to hear your interpretation of the Victor trial, and if you think that it will change the clinical practice regarding use of vericiguat. I don't know, do you use vericiguat in India?
We do use vericiguat in India. So, I mean, vericiguat has been used effectively in heart failure. And there is ample benefit that, even in, like if I showed that meta-analysis, and if you look at the SGLT2 inhibitors can easily be substituted with vericiguat, and they have shown nearly equivalent benefit. The cost is a limiting factor of vericiguat in heart failure, at least in our clinical setup, because not many patients can afford vericiguat. But yes, it is something of a molecule of promise.
There is a dose-dependent increase in the cyclic GMP levels with vericiguat. I think that is what is important. We should understand, don't stop at 2.5.
Yes.
Keep going up, because if you go up higher on the dose, the benefits are better with that.
That's right.
So the Victor trial, there were ambiguous results in a stable patient over and above quadruple therapy, upstream usage before worsening heart failure.
That's
This is
right.
what is the question. Said that the heart failure hospitalization, it was negative for that.
That's right.
But all-cause mortality, surprisingly, it's the only parameter in the subgroup analysis which is statistically significant. The investigators say, I'm disappointed, but I'm not deterred against using it upstream in order to prevent the further worsening, because it's so innocuous drug and it can marry with any existing regimen. So this was his final take. But otherwise, Bayer, as they say, is quite disappointed with Victor result. But only these one, all-cause mortality and some subsets of cardiovascular death was positive in 2.5 years of follow-up.
That's right.
Yeah. I think the problem with the Victor trial is the design. They have given too much liberty to the investigators to escalate diuretics. Many patients in practical real world don't like to be admitted. You just increase the diuretic dose, give one IV last diuretic furosemide dose, they may not get admitted. So if the investigator has not done that, the hospitalization rate would be more.
Well, I think it just reflects a different way, a novel way of treating patients of heart failure. Nowadays, we don't want to have patients in the hospital. We just optimize diuretic therapy. We give IV diuretics in the outpatient clinic. So probably the outcome of the trial didn't really reflect what we do in clinical
No, the problem
practice.
is the way they defined the primary endpoint. If they defined the primary endpoint, a worsening of heart failure, including decrease in functional class or emergency room visit or escalation of the diuretics or giving intravenous diuretic, if you keep it as a worsening of heart failure as an endpoint, probably it would have been positive. Right?
No,
Once you say hospitalization is different from worsening of heart failure. So if the the definition of the primary endpoint, if they were to make it worsening of heart failure and hospitalization, I mean mortality, then it would have been positive.
Yes, and it was in the post-hoc analysis that they did, but it's a post-hoc analysis. The other point is that 75% of patients or something like that were on diuretics at the baseline, and there were patients on GDMT. I mean, actually 75% of patients on diuretics, it's a lot on top of GDMT in patients with stable heart failure. We tend to actually remove diuretics from therapy. That's, in my opinion, another...
But probably have to see the fine print. What is the dose of diuretic? Taking 20 milligrams of furosemide is not equal to taking 160 milligrams of furosemide. So we have to look at the detail. And I think if they have changed the primary endpoint, composite endpoint to worsening of heart failure and mortality, it would have been positive.
I agree. The problem is the trial now is what it is, and that will not change.
Again, the difference
the pooled
between
analysis also, when they've done the pooled analysis of the Victor trial,
Yeah, but
they looked at NT-proBNP levels. So I
but
don't
the
know how much
pooled
that would-
analysis is, I mean, it's like putting together very different things and saying there is no heterogeneity. I mean, it's only 2 trials. It's even difficult to demonstrate heterogeneity. And the other problem is that if you look at the relative risk reduction, it's very small. So I will not really make a point on that.
The other difference was that compared to Victoria and Victor, SGLT2 inhibitor usage was very high in Victor. It was not very high there. It was hardly there in Victoria. Heart failure hospitalization was very high. Here you use SGLT2 inhibitors, the heart failure hospitalization significantly comes down. That's another very important thing that is there in the drugs used in between the two. Otherwise, pretty much the same. All other drugs were used. Stable patients, I think it's very, very interesting that it has reduced sudden cardiac death and death due to heart failure. I think both are what we are interested in, stable patients who have not had an event for 6 months. I think that in clinical practice makes a big difference. Your comment?
Yes, I mean, see, but if you look at the residual risk for sudden death, I wonder if you have read that there was a paper that came up in circulation, that although we feel that overall death has reduced, you know, the residual risk for sudden death is still significantly high. The proportion of patients who die suddenly in all these trials is disproportionately high. In all these Paradigm, Paragon, surprising the use of heart failure devices was low, and the residual risk of sudden death remained still at 30 to 40%. So
11% in this. Victor had 11% in the placebo arm.
So I mean, Victor I'm talking about all the other trials, ARNI trials. They all had a significant residual risk. So if followed long enough, these patients still have a risk for sudden death. What is the mode of death? Will it be an arrhythmic death? Will it be related to electromechanical dissociation? What will be the role of ICD is still unexplained. But I don't think so. You know, we can jump to the wagon and say no role for ICDs.
I think this is a great comment. I completely agree. So the point is that it's true that the drugs might reduce the risk of sudden cardiac death, but the residual risk is high. And if you take a population where the risk of dying of heart failure is low, actually the risk of sudden cardiac death is even higher because one competes with the other one. And that's why I think in a population like the Victoria trial, you see that the drug, the Victor trial, the drug is actually probably reducing the risk of mortality by reducing the risk of sudden cardiac death. So it makes very much sense, I agree.